I am joined tonight by many colleagues, collaborators, and partners on this presentation. It's our privilege to have you join us tonight and to present this information to you. So we are here for our annual break free from PFD or pelvic floor disorders. Next slide, please, Jackie. So as Cheryl mentioned, there's a couple housekeeping and Zoom tips. Many people might be more familiar with the Zoom capabilities. But for those of you that are a little more novice at this, there's an option to mute and unmute yourself. We just ask that you remain muted during the speaker presentations. There's stop and start video if you want to have your camera on so we can see your face. If you need to turn that off, just hit the video button until there's a red line through it. The chat is really important. If you want to put a question in, you can go down to the chat icon, and if you click on that, it'll open the chat function. You can enter your question or comment, and Jackie and Cheryl will help to draw our attention to that. And then if you want to raise your hand to ask a question, you can just hit the raise hand icon, and that will put a little hand on your picture, and we'll see that you have a question to ask. Next slide. So as I mentioned, I am joined this evening by many of my partners and collaborators and my fellows on this call. So you'll notice here many of the names of people will either be presenting this evening or will be available in the breakout rooms. So you will see all of these amazing folks tonight, and feel free to ask any of them any questions. Next slide. So Jackie, you can just keep going till the slide is full. So the Integrated Specialty Care for Women is the program at the University of Wisconsin that is an integrated multidisciplinary care for patients. So in that, we have different spokes on the wheel of all of the different types of subspecialists that will take care of the individual patient. So we have urogynecology, which are trained, fellowship trained surgeons in both urology and gynecology. We have sexual health experts, gastroenterology, colorectal surgery, and pelvic floor physical therapy. And all of these partners come together for the individual patient. The Integrated Specialty Care for Women program at UW has been around for almost a decade and a half, but we're moving over to the East Park Medical Center to provide that care in one location for women. And this is the only multidisciplinary program in the state of Wisconsin to do this. Next slide. So some of the information we're going to cover tonight, we're going to first discuss pelvic floor disorders. So what exactly are they, and how do we manage them? We're going to review bladder control issues, pelvic organ prolapse, bowel control issues, and we'll provide some additional resources that Cheryl and Jackie will make sure to mail out as well. And then there's a Q&A, but then we'll also have these breakout sessions. In the breakout sessions, there will be 4 of them. They will be the bladder control issues, pelvic organ prolapse, bowel control issues, and sexual health. And when you registered for this event, you were able to delineate if you wanted to go to a specific breakout, and you'll get more attention with the presenters of those breakout sessions and can ask even more questions. Next slide. All right, so we're gonna start here with a pop quiz. So as a woman, your chance of getting a pelvic floor disorder is it A, 1 in 3, B, 1 in 6, or C, 1 in 9? What do our guests think? How common are pelvic floor disorders? Does anyone want to share an answer? So a couple people are putting it in the chat. So I got a C, I got a couple A's, I got a couple B's. All right, so we'll go to the next slide. So the answer is A. The chance of developing a pelvic floor disorder in a woman's lifetime is about 1 in 3. So these conditions are actually much more common than many people think. And that's why it's even more important that we have this multidisciplinary collaborative clinic. Next slide. Well, what is the pelvic floor? It sounds kind of odd. It's like this thing that would be on the bottom of something, when really the pelvic floor describes a set of muscles, ligaments, and connective tissue in the lowest part of the pelvis. So if you look at the picture on the right side, we can see the internal organs of the bladder and the urethra, which is the tube that drains the bladder. We also see the female reproductive organs of the uterus and the vagina. And then we can see the rectum and the anus. And so the pelvic floor helps to support all of those things so that they can have healthy function. And so the pelvic floor is related to that. Next slide. Whenever a patient has a problem with a pelvic floor disorder, there can be an issue with any one of those organs then. They can have problems with bladder or bowel because the pelvic floor muscles are weak or the connective tissue that supports the pelvic floor has been stretched or damaged. So some of the possible symptoms includes bladder leakage, which we call urinary incontinence, symptoms of overactive bladder where you feel like, oh, I gotta go right now, or I have to go all the time. Difficulty emptying the bladder where it feels like you're always having urine left over. There may be issues with bowel movements where there's leakage or difficulty emptying, which is constipation. And some patients feel pelvic pressure or a vaginal bulge. And patients can also have sexual issues because of these conditions. Next slide. All right, so our next pop quiz. Which of the following are risk factors for pelvic floor disorders? So we have pregnancy, having more maturity or being older age, being overweight, smoking, or all of the above. And people are entering in the chat again. It's awesome. So it looks like everyone's choosing E so far, which is pretty unanimous. Okay, so we'll go to the next slide. And the answer is E. So we have certain things, I mean, risk factors for pelvic floor disorders, there's things that are within our control and there's things that are a little less controllable. So things that are in our control would be things that we choose to do. So lifestyle things, don't smoke, choosing to be more physically active and limiting excess fluids and caffeine and avoiding constipation. Another kind of general rule of health, of good health, is to maintain good health, keeping your pelvic floor healthy and controlling blood sugar. There are other things that are a little less controllable. So life stage, we know that these conditions increase with age. And so, if you're fortunate to have longevity, you may have a higher chance of seeing these things. Um, until medicine advances and men have equal opportunity to carry and birth children, the outcome of our species will require women to be pregnant and have children. So it's really not a modifiable risk factor. But there are some additional things that can maintain healthfulness. So pelvic surgery or pelvic injury might increase the chances, as well as neurologic problems. And then we know that like chronic lung disease with coughing can also cause some risk factors. All right, next slide. So urinary incontinence, Dr. Lynn is now going to take over and present this portion.
Thank you, Dr. Heisler. Everyone can hear me okay? All right. So in the US, over 78 million women have urinary incontinence. So we'll be going over the different types of urinary incontinence and the management for that. Go to the next slide. The basic anatomy in this diagram was shown previously, but the urethra and vaginal areas are actually separate openings. And this is shown in this diagram here with the urethra. I don't know if you can highlight that area with the arrow, but there's the urethral area that actually connects with the bladder, and that's the outlet for the bladder. And then the vaginal area is actually behind that, and they're close, but they're not the same thing. Go to the next slide. There's the bladder circle, bladder opening, there we go, and then vaginal opening. They're all sort of in a similar area. And how the bladder works is actually that the kidneys make urine, which then descends down into the bladder. The bladder is a storage organ. And to release urine from the bladder, there is a tube called the urethra. Now, muscles and nerves control the bladder function and also urethral function. And when the time is appropriate, hopefully several hours between urinations, there's a coordinated function that occurs where the bladder squeezes and the pelvic floor relaxes to allow urine to empty completely out of the body. So we got a pop quiz here. Bladder control problems only occur in women after menopause. Now, is this true or false? This is a little bit easier than the prior quizzes. There's only two answer choices. Okay, we got mostly B's coming on, which is false. And that's right, it is false. Women of all ages can be affected. Urinary incontinence is more common in older women, and it's up to 38% of those patients that are 80 years or older. However, the younger age group can also be affected by this, which it's about 1 in 4 for those that are 20 to 39 years old. Now, things such as pregnancy or excess weight can also affect urinary incontinence with pressure on the pelvic floor, issues like constipation, which you might not think can affect urinary incontinence as well, and also connective tissue disorders or problems. So when we take a look at the amount of time it actually takes for women to seek help with their specialists, it actually takes quite a bit of time. And if you look at this pie diagram, pie chart, um, you know, 41% of women seek help within a year. There's a third of patients, 33% actually, that wait between 1 to 5 years. And a quarter of the patients actually wait 5 or more years to seek help. And we see this commonly in our clinic from all providers, is that pelvic floor disorders simply are things that patients sort of wait around and seek care for, but we should really be seeing these patients sooner. This chart shows the types of urinary incontinence. We'll start on the left side, which is stress incontinence. Now, this isn't when you get stressed out, but rather this is the type of urinary leakage that occurs with activity. So things like coughing, sneezing, laughing, lifting, and exercising. Patients may describe leaking when they go for a run or a walk, or when they lift up a child or a grandchild. The middle category is urge incontinence. This is part of overactive bladder. This is a little bit different and not typically related to activity. The urge to go may occur suddenly with great urgency. There may be significant frequency. You have to go to the bathroom very frequently. May not actually make it to the toilet and may start dribbling on the way to the toilet or before you're actually ready to sit on the toilet seat. And possibly also nocturia, which just describes going to the bathroom frequently in the middle of the night. The last category sort of encompasses a combination of both stress incontinence and urge incontinence, and that's called mixed incontinence. So typically some patients can have both symptoms. And then there's continuous or unpredictable incontinence, which doesn't fall into the other two categories as well. Here's another pop quiz. Making changes to your diet may help control urinary incontinence. Is that true or false? There's easier questions on this section of the lecture tonight. Okay, seeing mostly A's. All right. It's true. What can you do? Well, there's lifestyle changes. So maintaining healthy weight can make a difference. Limiting alcohol and caffeine intake, avoiding excess fluid intake can also help, and avoiding constipation. Now, many times we think that we're going to the bathroom more frequently than we really do. So a bladder diary can record how often we are actually making trips to the bathroom. We can also try other things such as scheduling bathroom trips, which sometimes is called timed voiding. For treatment options, there's a number of sort of opportunities. As healthcare providers, we can also recommend lifestyle changes, performing a bladder diary with timed voiding, and then also some pelvic floor exercises such as Kegels with a physical therapist. Now, depending on the type of urinary incontinence you may be encountering or experiencing, there may be a combination of therapies needed. And every patient is different, so we'd like to tailor our therapies towards what the patient's goals are. And many times we hear patients come in with a friend or family member that may have had a particular type of procedure or treatment pathway, and that might not be appropriate for you, but happy to discuss. Some of the therapy options we manage in the clinic for overactive bladder include conservative management, so bladder training, behavioral modifications or changes, dietary changes, and then also physical therapy. There are a number of medications as well that can help relax the bladder muscle and prevent it from squeezing or having urinary leakage. There are some advanced, minimally invasive options as well, including a nerve stimulation through the ankle, which I like to think of it as acupuncture for the bladder. There's Botox injections for the bladder muscle as well. We're familiar with this in the cosmetic area. People get injections of Botox in their faces, but we do inject it in the bladder for leakage. And finally, there's a device that we place to help control the nerves of the bladder. It's similar to a pacemaker. And then combinations of all of those therapies can be used for overactive bladder. For the stress incontinence treatment options, which is that activity-related leakage with coughing, lifting something heavy, or laughing, there's conservative management again, bladder training, behavioral modifications, physical therapy. Sometimes a device called a pessary can be used. Now, these are devices typically made of silicone that can go into the vaginal space and support the bladder and urethra to prevent leakage. These can be fitted in the office. There are some over-the-counter devices as well that sort of fit into this realm of intravaginal management. Advanced therapies can include urethral bulking injections, and also surgeries such as slings that can be used. And the material for those is typically mesh, but there are some other options that don't include mesh.
All right. Well, now I get the chance to talk to you a bit about pelvic organ prolapse, which we commonly just refer to as prolapse. Maybe you've heard this term before, but hopefully you get a little more information about it tonight. So this, like the other pelvic floor disorders, is really common, and we see it in about half of women who are over 40 years old in some shape or form. So the anatomy of prolapse can be a little bit difficult to understand because it happens in part of our body that is not easy to see. But you can see in the pictures on the bottom here, just to orient you to what you're seeing, these show if we cut you in half down the middle and we're looking from the inside out, what is happening to the organs inside. So prolapse in general is what happens when those pelvic floor muscles that were mentioned and the ligaments that are attaching to your pelvic floor organs are getting too stretched or starting to become too weak to hold everything up high where it started. And things start dropping lower and lower down into your pelvis. And as it progresses, and some people it does, some people it doesn't, you might feel a bulging coming out of your vagina. And that is typically prolapse. So these pictures, we can just, all right. So yeah, I was going to just go over the pictures on the bottom here. So the pictures on the bottom here just show different types of prolapse. So sometimes these terms can get really confusing as well. So on the left, it shows what we call a cystocele, which just means dropping of the front wall of the vagina, and the bladder sits on top of that wall. So sometimes people will refer to that as bladder prolapse. The second picture there shows what we call a rectocele, which again just means dropping of the back wall of the vagina. And the rectum happens to sit behind that wall. So some people will call that a rectal prolapse, even though that gets really confusing because that term is used for a different type of prolapse as well. And then finally, the third picture here shows the uterus dropping out of the vagina, which is a little easier usually to understand, and we call that uterine prolapse. Now we can move on. So prolapse can have a number of different symptoms. People experience it in different ways, but some really common ways that people describe their symptoms are one, pelvic discomfort, just describing kind of a pressure or a heaviness down in the bottom in the pelvic area, typically not painful. Bulging is a really common symptom where you could actually feel something coming out of the vaginal opening. You might also have associated bladder problems. These might or might not be related to your prolapse, so potentially difficulty starting your urine stream or feeling like you have a weak urine stream. And then bowel problems can be associated as well. So you might feel like you have to strain a lot or push to have a bowel movement, or might have this feeling of stool getting stuck and you have to push it out. So there are a number of ways to treat prolapse with or without surgery, which is great. And whether we treat it or not really depends on if it bothers you. So luckily, it's not a dangerous condition at all. So we never really have to treat it if it's not bothersome. But when it is, what we want to go by is how it affects your quality of life and your sexual health and how we could make those things better for you. So some ways to avoid surgery and treat prolapse are one, by doing pelvic floor physical therapy. And there are some absolutely amazing physical therapists that are in our area here. And this really can make this much, much better in such a low risk way. Another low risk option is to use a device called a pessary, which Dr. Lynn had mentioned for treatment of stress incontinence as well. And that is just that silicone ring or kind of other shapes, but a silicone insert that goes in the vagina and really just acts as a brace, holding everything up. And then we can go into surgical options. So we always talk about goals of surgery with our patients who are interested in this. So, what we want to do is help you restore function to your life, get back to the activities that you want to do. We don't want you to have to feel that bulge anymore and overall improve your quality of life. We absolutely understand that everybody is different, their desires are different, their risk tolerance is different. So we have a lot of different surgeries that we can do for prolapse and work with you to make it a good fit surgery for you. When we're thinking about which surgery is best for you, we consider a bunch of different options like your particular anatomy, potentially your medical problems, your overall health status, what prior surgeries you've had. And then, we all, as the surgeons, have different experience and training and some different expertise in different types of surgeries as well. So a key point here is, don't compare to others. So others' success or failure of maybe an operation that they had should not be the deciding factor for you because everyone is really so different and the surgeries are so different.
Thank you, Dr. Cox. Dr. Hayden, are you still with us here?
Yeah.
Perfect. I know you were taking care of an ill patient, so I just wanted to make sure you were.
Yeah, sorry about that.
That's okay.
Okay. I'm not seeing the screen, but that might just be me. Are you guys seeing the slides?
Yes.
Oh, shoot. Hold on. I'm not.
Do you want me to run through the
Okay.
slides, Dr. Hayden, or you
I
got
see
it?
it. Nope, I got it.
Okay.
Yep.
Thank you.
All right, guys. Okay, so hi guys, I'm Dana Hayden. I'm one of the colorectal surgeons, and I'll be talking about controlling our bowel movements. Next slide. So the symptoms are extremely variable. There's a huge spectrum of what people call like trouble controlling their bowel movements. Sometimes it can be as kind of infrequent or super frequent, but just really having trouble controlling just passage of gas. It can sometimes just be looser bowel movements that people have control issues with, or it can be very infrequently, or maybe even with solid stools, or can happen all of the time. So the frequency of symptoms and actually what the symptoms entail can be like kind of occur on this long spectrum. But what is pretty common is that no one really loves to talk about this. So it is, there's a lot of patients that just might not ever bring it up to their primary care provider or their gynecologist or their family medicine doctor. So it takes a while for patients to actually come in and finally see a colorectal surgeon. Next slide. So the people who tend to go into colorectal surgery were like super comfortable talking about pooping in your pants and symptoms like that. But it absolutely can be upsetting and embarrassing. And that's probably one of the reasons why it takes a while for people to come in once they're just like, miserable enough that it will just get over having to talk about things that can be this embarrassing. It is something we talk about all the time. So you should never feel ashamed. You should never be embarrassed. And this is our job. So we're more than happy to talk to you about it. And hopefully we'll do a good job putting you at ease, talking about something that can make you feel a little uncomfortable. And what's great is that there's a whole like group of treatment options that we have that may not even require surgery to get their symptoms under control. Next slide. So basically, how bowel continence works, similar to the presentation we've seen for the urinary side, very close by is the rectal side. And there's a bunch of muscles and nerves that all work together within the pelvic floor to help us defecate normally. So not only do you have an urge to have a bowel movement when the rectum is full, there's a whole process and a whole feedback loop that allows you to actually hold off on having bowel movements. And then when you're ready to actually allow you to sit on the toilet, you get the sense that you're about to go to the bathroom, and then your rectum to actually straighten. A really complex system, which is kind of amazing that it works that way. But there's, again, plenty of places where this system can go wrong. Next slide. So like we talked, I'm cutting in and out. I'm sorry, guys. Let me know. Give me a second. Let's see what this is going. Let me try to find a good spot. Oh boy. Can you guys hear me okay right now?
Yes, we can.
Okay, I'm sorry. Okay. So kind of like what we talked about a little bit earlier, the symptoms of bowel control problems are this huge spectrum. And it can just be losing gas. It can be losing liquid stool or solid stool. Sometimes it can be described, there can be overflow incontinence where actually you're constipated, but then you're losing liquid stool around constipated stool. And it's actually a constipation problem more than it is a control issue. And then finally, people have tons of like loose stools all the time and chronic diarrhea, that's also can lead to having difficulty controlling loose stools all the time. Next slide. So we always start with conservative management first. And what I mean by that is really looking into why we're having trouble with control. And it usually starts with bowel or diet changes. So you want to make sure that you're eating a healthy diet full of fiber to help bulk up that stool and make it easier to control and easier to pass. Again, you want to avoid foods that cause diarrhea. And that can be, increased alcohol, caffeine, or spicy food, kind of all the good things, unfortunately. And then if you tend towards constipation, then to make sure that you're having actually a good bowel regimen, which might require stool softeners or laxatives and fiber to improve the constipation, to then decrease the risk of that liquid stool kind of passing along the constipated stool. Next slide. Other options short of surgery include physical therapy. And this is really one of the mainstays of our treatment. And basically, depending on what the reason for the bowel dysfunction is or the trouble with control, we have physical therapists that are going to do bowel retraining, that are going to strengthen those muscles if the muscles are weak, that are going to help with coordination. Sometimes it's a coordination problem between all those muscles and nerves. And this is a huge part of our treatment algorithm. And then again, like I mentioned, making sure you're on a good bowel regimen to help you have easy, soft bowel movements that have enough bulk in it. And that's where the fiber helps. Sometimes if you have loose stools all the time, we may even put you on an anti-diarrheal to help slow that down. Next slide. So we do have some other, kind of what was mentioned before, some inserts that can either be placed rectally or vaginally to help control leakage of stools. These I'm not super familiar with, but they can just help give you some temporary um, uh, control when if you have like an event to go to. Next slide. And then surgery. So surgery is an option for fecal incontinence, but we pretty much reserve it to people that have severe incontinence and that have symptoms all the time and that have gone through all the conservative measures. And the different types of surgery include bulking agents, the bowel pacemaker, kind of what was already mentioned by Dr. Lin, and also sphincter repair. Next slide. Okay, I love these pop quizzes. Is living with a PFD a normal part of aging? So pelvic floor dysfunction, is it normal part of aging? A is yes and B is no. Okay, looks like we have some A's, we have some B's. This is probably the toughest question of the day. Some A's, some B's. Okay, great. So I don't know, depending on the day, I'm not sure as I'm getting older if I would have answered this correct. It's not a part of normal aging. So there's usually some other event that kind of led to having pelvic floor dysfunction. And that's one of the things we talk about in the office is try to identify what may have like led to the dysfunction. And that really can help us get you on the right path towards fixing the problem and helping the symptoms.
All right. Thank you so much, Dr. Hayden. And sorry for the tech troubles.
No, it's my fault. Thank you,
Appreciate
guys.
you being here, and I appreciate your time here too. It's hard when clinical care is also needed, but we're grateful for you. So I think the takeaway message from tonight is that, patients, they're not alone. The people that we see, these conditions are really common. They're common at all ages. And there's nothing that you could say to us that we haven't heard from other people or conditions that we haven't seen before. So there's so many, experienced providers that are familiar with these conditions and the range of treatments, they're so vast that we want people to feel hopeful and we want them to feel really shepherded along this journey to get the help that they need. There is this voicesforpfd.org, which is where you can share your story, get support, and you also have the opportunity to ask experts about pelvic floor disorders. So as a resource, finding some collegiality amongst other patients, this is a really good resource. Next slide. So some other resources that are available are included here, and these can be emailed out to folks, so please don't rush to write them down. So if you'd like, we can include these in the email that goes out. And then next slide. All right, so it was mentioned earlier that we have amazing pelvic floor physical therapy providers in Madison, and that's absolutely true. We have a few different groups in town. We're joined tonight by some of our UW physical therapists, and they are the therapists that work with us in the integrated specialty care for women. Depending on insurance type, sometimes other physical therapists will be involved in care. And so we just wanted to provide the resources for all of our physical therapy partners in the area and the phone numbers to reach them if needed. Next slide. Excuse me. So as I mentioned, the Integrated Specialty Care for Women program is moving to East Park Medical Center. We're moving mid-November. So we wanted to share the single number, which is 608-914-0800 for the Integrated Specialty Care for Women program. And then we also have the one number for the sexual health program, which Madeline Esposito, who's joined us tonight, is going to be is the medical director. So we have a great team of people ready to support and care for all of our patients. And so those numbers are available to you all. And we'll take the next slide. All right, so we have wound down with our general information session. In just a few minutes, we'll allow people a chance to go and use the restroom. I don't know about you guys, but all the talk about urinary incontinence all day long with my patients sometimes makes me feel like I have to go to the bathroom. But if people want to take a minute to use the restroom, in about 5 minutes, we're going to have folks be brought to their breakout rooms. So Jackie has been really great about helping with that. The breakout room options that are listed here are a little bit different this time, just because of the availability of our presenters, but there's going to be 4 breakout rooms. And if you have any trouble, just chat with the AV tech and they'll be able to put you in a room. Next slide. Perfect. So some additional references here as well. So the the list of these references can be sent to patients, and we'll make sure that everyone has those. And then I see in the chat there's a couple other conditions or a couple other questions. So yeah, Dorothy made a great comment that these conditions are common but not normal. And I think that's a really important distinction. They shouldn't be normalized as something that people have to suffer from if they're impacting your quality of life. There's options for help and there's hope for improvement. And then Patricia, you asked the question about how regarding radiation therapy, and then not really knowing how to make the appointment. And then Haley mentioned that we'll read that you can reach out to us. You can give us a call. The number for so do you Haley, do you want to give the number? Can you just write that in there, please? And then the next question for Jane is how do you diagnose pelvic floor disorders? And that's a really great question. So ultimately, if patients are experiencing symptoms of these conditions, and they come in to see us, we would do a physical examination in addition to getting a history and getting more information from you. So through your history that you share and the symptoms that you're experiencing and the physical exam, that's how we would diagnose it. So it doesn't require imaging. It requires seeing one of the amazing providers available on this in this presentation tonight, or any of our other partners who couldn't be here tonight. So we have a big cadre of folks that can help with that. Um, so sometimes we do imaging, like MRIs, what Dr. Hayden was mentioning about some defecation issues. Sometimes MRIs can be helpful with that. So that's more for some functional things, but overall, we don't have to do any sort of imaging for that. It's based on an exam in the clinic. Um, and then, so we have the number here for the integrated specialty care for women, and I believe that number is live, and we should be able to get you scheduled with us. Um, and there was a question earlier about a best brand of stool softener, and the brand is not, I don't know that there's a best brand, but stool softeners would include medicines like Docusate, and that can be bought over the counter, like at CVS or Walgreens or Target or Walmart. But that would be a good stool softener. Sorry, I was trying to keep up with all the questions in the chat throughout the presentations as well. So I hope that was helpful to folks. We're so grateful for everyone to be here. Um, all right, that's perfect. So why don't we take a few minutes? Let's plan to do the breakout session starting at 6:45. If folks are a little late, that's okay. So thank you, everyone. We'll see you in the breakout sessions. All right. Well, on the heels of that, I think we're good to have everyone sign off. So thank you again, partners, colleagues, collaborators, and for our community partners for showing up today. Have a good night, everyone.
Good night,
Night.
everybody.